Perfect. All right. All right, can you see that? Okay, good afternoon, everybody. It's a pleasure to be here today and share this talk about memory changes throughout the course of aging and when that might be normal and when it might not be normal. There's three speakers today. Myself, I'm a nurse practitioner in the Senior Care Options Department here at the 10 Gove Street Clinic. I've also got Dr. Simon, who is the medical director of the Senior Care Options Department and a primary care provider in the adult medicine department, who's been here for over 30 years, a specialist in gerontology. And I've also got Dr. Jim Padula, who is the medical director of our PACE program, who has been at the clinic for over 35 years. So we have some experts in the room. Looking forward to sharing our talk with you. So to get started, we all age, and as we age, there's a lot of changes that take place throughout the body. The brain that controls the body, it also controls how we move and speak, is one of the organs that can be affected with aging. And so over time, some of the brain cells can get damaged, and that decreases the brain's ability to function as it once did. These changes can lead to people having some trouble performing normal tasks, some changes with memory or language. So small changes with memory or functional status can be normal and can be expected as we age. But bigger changes can make it difficult to do your everyday tasks, such as driving, using the phone, taking care of yourself, bathing, dressing. And when those things start to happen, that could indicate that there's a more serious process going on that isn't necessarily related to aging. So today we wanted to do a overview of some normal aging changes and then symptoms that may be more concerning for a more serious illness such as dementia or Alzheimer's disease. The main point is that if you're concerned about memory changes for yourself or a loved one, you should reach out to your medical team as soon as possible to discuss these because as you'll learn throughout our talk, early diagnosis can lead to better outcomes in the future. Okay, so I wanted to start us off with a story. So this is a pretty common story. It's sort of a compilation of the story of many of my patients that I've seen over the years. So you are living in a multi-generational household with your mom, who's 70 years old, and your two children. Your mom helps look after the kids when you're at work. But as she's gotten older, you've started to help her with a few things like grocery shopping, lifting some heavy items, doing some of the house cleaning, things like that. Over the last year, though, you've noticed a few changes. She frequently misplaces her keys or phone, but she eventually does find them. This is really common, one of the first changes that people notice. Sometimes she forgets someone's name or if she had a doctor's appointment, but then she'll remember it later. Last month when she was paying the electric bill, she put the wrong amount, but she still paid the bill. She said it was Tuesday when it was actually Wednesday, but then she realized her mistake shortly thereafter and corrected herself. Sometimes she forgets the word she wants to say, but then she usually remembers it. She's often very social. She loves doing things with her community and family, but recently there was a family event and she just didn't feel like going. You, as her daughter, get a little bit worried because your mom's sister, your auntie, had Alzheimer's disease. But you just think that these things are mild and you think maybe it's because she's getting older. Over the next year, you notice a few more changes with your mom. When she was going to Walgreens recently, she got lost and she couldn't find her way home. She used to go there every single day with no problem. Luckily, she called you on the phone and was able to get home. Sometimes you notice she repeats the same question over and over again. Um, Last week, when she was trying to follow your abuela's favorite recipe, she just couldn't seem to get the directions correct, which you thought was really strange. Her appetite isn't as good as it once was. And recently, she missed two doctor's appointments. When you asked her about it, she didn't even remember that she had those appointments. Before, she always took herself to her appointments and was very attentive to all of her doctor's appointments. So that was a big change. So now I want to talk to you a little bit about dementia and Alzheimer's disease. So when we think about memory loss, there's a lot of words that might be getting tossed out there. You might have heard of dementia or Alzheimer's disease, but aren't really sure exactly what they mean. So dementia is an umbrella term that encompasses or it sort of it looks over many different terms. So it's a broad term, and there are more specific diseases that fall within that umbrella term. So dementia is used to describe a range of neurological conditions that affect the brain. More specifically, you may hear about Alzheimer's disease, which is the most common form of dementia. It's usually about 60 to 80% of all dementias, and it's a brain disorder that slowly destroys memory and thinking skills, and it ultimately makes it very difficult to do activities of daily living. There is a small genetic component to this if you have a first degree relative. The second type of dementia that's second most common is vascular dementia. This is a disorder that is caused by stroke or other conditions that disrupt blood flow to the brain. And this can lead to similar problems with memory, thinking, and behavior. Diseases that affect the blood vessels, like high blood pressure, diabetes, or high cholesterol, can increase your risk of vascular dementia. The next most common type is Lewy body dementia, and this is similarly causes issues with thinking and memory, but also has a component of a movement disorder where you may see tremors. And it also can affect behavior. So you may notice somebody mentioning hallucinations. One of the common features of this dementia is that it has fluctuating symptoms. So the symptoms sort of come and go. So you may have days or times where you're doing great, and then other times where you notice a lot more symptoms. And then a less common type of dementia is frontotemporal dementia, which affects certain parts of the brain and can cause issues with thinking and behaviors as well. This type of dementia is about 1/3 genetic, so it has one of the strongest associations with a genetic inheritance. Now I'm going to pass it over to Dr. Simon to go over some demographics.
So I was going to get us started with talking a little bit about demographics or kind of population numbers. And this is a chart maybe many of you have seen, is that basically America is getting older and older and we're living longer and longer. And this is some projections of population that we're expected to see in America for folks over 65. And kind of the population a couple of years ago was thought to be about 58 million people living in America who are 65 or older. And that number is expected to go up to 82 million by 2050. You guys are familiar with the baby boomer population, those born between 1946 and 64, very, very large population. By 2030, all of those, that very large population, will be turning 65. That's going to have a lot of effect on a lot of parts of our country when a larger proportion of our population will be over 65. Now, it's thought that the proportion of older individuals with dementia is declining a very small amount, but with the numbers of people going up much higher, the number of, of, of people in the United States with dementia will increase significantly in the next 30 years or so. So that's an important thing that we need to keep an eye on. Next slide, please. This is more of a as far as dementia as a whole, who's at higher risk, and really the most common groups are obviously people who are older. The likelihood of getting dementia goes up with age. Those who have attained less education, and this is just a chart with education levels, and folks with less than 12 years of education total have a much higher likelihood of developing dementia. Women just slightly higher risk than men, and race and ethnicity, Hispanics and Black non-Hispanics have a pretty significant increase risk of developing dementia. There's probably a lot of reasons for that, things that we're not able to get into now. I think we can save that for another talk. Next slide. And this is kind of more of an individual risk factor, who on a more personal level is more likely to develop a dementia through their lifetime, and kind of break these down into things that you can fix, or things you cannot fix, and things that you could fix. The things that you really can't do anything about are your age, your genes, and your family history. But we really want to focus on things that we can do something about. Trying to avoid traumatic brain injury, avoiding smoking, diet. It's been shown that diets low in fruits and vegetables and grains and high in red meats tend to develop a higher rate of dementia. Physical activity, we've all heard about exercise. It's been shown that if you can get about 30 minutes a day, 5 days a week of light walking, that has been shown in many studies to reduce the likelihood of getting dementia. Education, as I pointed out in the previous slide, very important. Folks who are isolated, who don't get contact with many other people, which is very common as our population gets older, certainly has an association with dementia. Medical conditions like high blood pressure, cardiovascular disease, and diabetes. Sleep, very important. We all need to focus on our sleep. So it's been shown that having too little sleep, having disrupted sleep, having a sleep schedule that's not regular, we all fight that, can lead to lots of things, including a higher risk of developing dementia. Sensory loss, people who can't hear well, who can't see well, maybe a little bit more isolated and are more likely to develop dementia. And then things that we may or may not be able to control are air pollution and other toxins in the environment that we all hear about have a higher risk. Next slide.
Okay, thank you for that overview. So one thing we wanted to demonstrate is some examples of what normal aging changes look like versus things that might be more concerning for dementia. So with normal aging, if you notice your loved one making a bad decision every once in a while, that could be part of normal aging. But if you notice that they're having poor judgments or decision making a lot of the time, every single day with different situations, that's definitely more concerning. With normal aging, if they were to make a small mistake by missing a bill or writing the wrong number, that's could be normal aging. But if they have problems taking care of their monthly bills when before they could have done it easily, that's an indicator that you should reach out to a healthcare provider. If they forget what day it is but remember it later, that's pretty common, and that may be normal aging. But if you ask what day it is or what date it is or what time it is, and they frequently don't remember what that is or tell you the wrong answer, you want to reach out. If they sometimes forget a word, that's, not too abnormal, but if they're having difficulty having a conversation, repeating themselves frequently, forgetting what you spoke about earlier, those are things to be a little concerned about. And then I feel like my patients ask me about this all the time, but they say I misplace my phone or keys, but then find them later. So that might be normal aging, but if you're misplacing things all of the time, or maybe locking yourself out of the house because you don't remember where you put the keys, that would be a little bit more concerning. So those are some examples. And if you ever are concerned about memory changes, you should certainly reach out to your medical team and we can provide an evaluation to try to help you figure out what's normal or not. So Dr. Simon mentioned briefly some of the modifiable risk factors or things that we can change. So prevention is really important. And there's no proven method for preventing Alzheimer's disease or dementias, but there are things that may reduce risk. So especially for vascular dementia, but also for Alzheimer's, controlling your blood pressure is really important. So if you have high blood pressure, you want to make sure that you try to get the best control throughout the course of your life. So regular follow-ups are really important. Same with blood sugar. If you have diabetes or prediabetes, making sure that those are controlled throughout your life can help prevent damage to the blood vessels, which can prevent damage to the blood vessels in the brain as well as throughout your body. So that's really important. Maintaining a healthy weight has also been shown to have to be beneficial for prevention. Quitting smoking. Smoking also can damage blood vessels. So if you quit smoking, that can help prevent any blood vessel damage within your brain. Getting enough sleep and restful sleep is important, as Dr. Simon mentioned. If you notice any sleep issues, especially like restless leg syndrome, or you're having difficulty breathing at night, you would want to reach out to your provider. Eating a balanced diet is very beneficial. Fruits, vegetables, whole grains, healthy fats, and then trying to limit things that have saturated fat like red meat or a lot of sugar. Keeping physically active is great. As we mentioned, 30 minutes of light activity 5 times a day has been shown to be helpful. Taking care of your mental health is really important. If you have any concerns about depression, anxiety, or other concerns with stress, you can reach out and get assistance with those, and that would be very helpful. Staying socially active has been found to be very helpful. We noticed during the pandemic a lot that our elders became isolated and the incidence of memory-related disorders actually went up. So staying socially active is really important. Also staying mentally active, so challenging your brain to do different things has been shown to be helpful. One of the things you can do is try to learn something new. That's really great for building new pathways in your brain, so it can be helpful to prevent any memory issues. Playing cards, board games, reading, sharing with others things that you love to talk about, or listening to blogs or podcasts or other electronically recorded things can be helpful. And then making sure that you can hear well. If you're noticing hearing loss, getting hearing aids has actually been shown to be beneficial to prevent memory-related issues. And then, as we mentioned, avoiding head trauma, so making sure to wear your seatbelt, wearing helmet as appropriate, and then for older folks, preventing falls is super important. You want to try to minimize clutter throughout your house, maybe try to get rid of some of those throw rugs that you could trip over or other items on the ground, and making sure that you have good lighting. Your primary care team can talk to you about ways to reduce clutter and reduce your risk of falls at home. All right, and I'm going to pass it to Dr. Padula.
Well, the observation, people's either self-observation or from their family of displaying some of the things that Celia had mentioned earlier about difficulty with tasks they were once successful with, or memory issues can provoke a lot of stress and anxiety and fear, and even lead to some denial that may delay, outreach for care. It's understandable. Um, but it's important to proceed early, especially currently, because of the enormous research that's continuing and progress that's being made in terms of hopefully one day either markedly slowing progression of these illnesses or their treatments. So basically, it permits the opportunity for two different things, both medical and support service planning, but also life planning to detect it early. And so it's like we mentioned to seek medical evaluation early. That'll be talked about in more detail later. So we want it allows time to plan for the future. There may be decisions that a person may wish to make about their own retirement, about driving, about selecting someone who can speak for him or her. If God forbid, but at some point in the future, it's difficult for them to make complex decisions for themselves. It increases the chances of participating in clinical studies that, as I mentioned, are large and continuing every day. Um, you'll have the person then has their opportunity to express to their family their wishes as circumstances change in the course of their illness. You can develop a relationship with the important medical providers that will be caring for your relative or yourself over the course of time. And then what we'll also talk about earlier, but is it's important once there are need for supports that a person is aware of the access they have to supports that can provide their caregivers, or they the ability to provide for supports throughout the day as there's need for more support. So very important to proceed to care to, and then hopefully it may turn out that other things like particular medications or other things may be contributory to the symptoms that are observed, which would be wonderful news, but it's important for someone to assess that early.
Thank you. So you come to this lecture and you realize that there's the importance of reaching out early. And so you finally decide to talk to your mom about her memory changes. You can start off the conversation by saying, I've noticed changes, and then you can describe what you've seen. And then you want to ask if they've noticed anything. Has your loved one noticed anything? Because they may have a different perception of what's going on than you do. So your mom states that she's also noticed some changes and she wants to see her doctor. So as her caregiver, it's really important that you go with her to that appointment so you both can share your perspectives about what's been going on. So I want to just go over a little bit about what you can expect at a medical appointment for an evaluation for memory loss. You're going to get a lot of different questions just about things that you've noticed, what changes have been made, what medications you're taking, how your functional status is. Because just because you've noticed changes with memory doesn't mean that there's something going on with your brain. There could be other issues that are causing your changes. So we want to make sure we do a comprehensive evaluation to understand that. Um, there are some validated tests that we use to test memory, and we're going to go over those a little bit more. We may send you for blood work so we can rule out other things that could be causing the memory changes, such as a blood count, electrolytes, kidney function tests, liver function tests, some vitamins, thyroid function, and some infectious diseases. Depending on the evaluation, your provider may or may not order head imaging. So we'll talk about that a little bit more.
So as Celia was saying, well, so you've decided that, this may be something concerning, so you make an appointment and come to see your provider. So exactly what's going to happen? How are we able to to figure out if this is kind of normal memory issues of aging versus something more serious. So like everything we do, we're going to start with a good history and also a physical exam. But the history, we're going to want to know when it started, how quickly it's progressed, if it's rapid. Certainly we're going to want to know if there's any family history. Very important, as we mentioned, that family history and genetic causes are very important. Everybody has a concern about a family history. You can help to discern with detail what might be significant and what might not be significant for you. Certainly, we're going to look very closely at the medications. A lot of older individuals who may show up with a memory issue are often taking lots of medications, and we have to look really closely at side effects of individual medications, and sometimes medications don't go well together, and there are interactions that we need to think about. We're always going to ask about alcohol and other substances which can be going on in the background. It can have significant effects on somebody's memory and cognitive status. We'll spend a lot of time teasing out somebody's mood if there's an issue with depression or anxiety. As individuals age, the way that they show up or the way that they'll present with depression may be very different than a younger person. It will affect various aspects of their cognition, including memory, and it could be something as simple as some depression or stress. So it's very important to tease out what's going on. Is there any stresses? Are there any family stresses? Is there any changes going on in the house or in our patients' lives that we need to know about? Behavioral issues, certainly changes in personality. We talked a little bit about sleep, but a whole host of things that we'll need to think about. And then functional assessment is very important. We break those out into something called ADLs, which are activities of daily living, and then IADLs, which are more called instrumental ADLs, which are more higher function. So ADLs would be the personal things like eating and going to the bathroom and dressing and personal hygiene, things that are a little bit more basic. And then the IADLs are a little bit more higher functioning, taking care of medications, taking care of finances, arranging transportation, doing laundry, and just kind of higher level household. So we're really going to try to tease that out as far as if there's any loss of function there, which could go along with something more serious than just a benign memory. So as Celia mentioned, there are some very standardized tests that we did. One of them is called the mini-cog, and I think this is more for a screening, where it's very simple. We'll ask somebody to repeat 3 words, and we'll tell them to remember these words because I'm going to ask you to repeat them again. And then we're going to have them draw a clock, put the numbers on the clock, and then put hands on for a specified time. And this is a really good example of what can be normal. It doesn't have to be perfect, but that's certainly a normal on the left. MCI is mild cognitive impairment, getting a little bit off, and sometimes, to our surprise, we may see something on the far right, which would suggest that something very serious is going on. And then, as Celia mentioned, there are some more formal cognitive screening tests that we do. The most common one is called the Montreal Cognitive Assessment. You may have heard it called MoCA. It tends to be the highest accurate. It's a little harder to perform. It's been said to take about 10 to 12 minutes to perform, and it may not be as good for people who don't speak English. Another one, probably a little more old-fashioned, is called the Folstein Mini Mental. It's a little bit easier. We can do that in about 10 minutes, maybe 5 to 10. Again, a little bit less accurate, not the best for English-speaking patients. And then there's a very good one called RUDIS, which is very good for people who don't speak English. It does take a little longer to do that one. May take about 10 to 15 minutes to do in the office. Next slide, please. So this is an example of the MoCA. The actual test is on the left, and it's a whole host of things. The diagram on the right is really helpful to understand that when we do a screening test, we're not just looking at memory. Having cognitive impairment involves a lot more function, higher brain function than just memory. It's orientation. Do I know when it is or where I am? language abilities, naming, abstraction, which was the clock draw. We may have them draw pentagons in a special shape that they have to draw. And then attention and focus is a large one. And we have various questions that we can ask. Some of them are harder than others, but we gear how we can test folks. But we do this a lot. It takes time, but we kind of roll up our sleeves and find the time to get this done because it's so critically important. Next slide. And then when we're thinking of it, as Sonia mentioned, Alzheimer's is certainly a subset of dementia, and there are other causes of dementia, and then there are other medical causes that might not be a primary neurologic dementia. Certainly, we mentioned mood issues like depression and anxiety, other medical conditions, thyroid, vitamin deficiencies, infections, and certainly way up on the list is medications. We are going to really harp on that because we need to look at that very closely. And then other neurologic conditions, Parkinson's, vascular disease such as strokes. Everybody worries about a tumor. They're very, very rare. But that's something that we're going to think about. And then there are several other kind of less common neurological conditions that we're going to look at. So as Celia mentioned, we're going to do a lot of blood work, most commonly looking for thyroid abnormalities. Thyroid is a hormone that kind of keeps our metabolism going, and it's very common to be high, very common to be low, and it causes a lot of symptoms, including memory and problems with cognition. B12 deficiency, old infections like syphilis. We actually bring up syphilis and we test for it and we talk to our patients about that. It could be something that happened 50, 60 years ago. And we have to communicate with our patients about that. And as Celia mentioned, very likely that we're going to do a scan. MRIs are best. CT scan we'll use if we're not able to get an MRI for various reasons. And we're going to be looking for small strokes, tumors. Atrophy is a sense of the brain getting smaller. Our brains shrink as we get older, and radiologists are pretty good at figuring out what's a normal amount of atrophy or getting smaller, and what is something that really somebody shouldn't have. And then there are other findings as well. And then we may send people for more complex, what's called neuropsychological testing, which is very long and extensive. Keep in mind that from a primary care standpoint, we really don't have a test to say that you have Alzheimer's. Alzheimer's really, from what we have, is the word we use is a diagnosis of exclusion. We're going to try to make sure you don't have everything else that we could potentially fix or reverse, and then say, well, it doesn't look like you have anything else worrisome. This looks like it's Alzheimer's. And certainly we'll also refer to a neurologist who will help. And there are newer studies that neurologists are doing that can help to make an actual diagnosis of Alzheimer's.
After the sort of determination has been made that perhaps even at the earliest stages or so of true Alzheimer's dementia has developed, as Dr. Simon outlined, many, of course, have questions about what can be done at this point in time, what can help with my relative or me to help with these particular things we're observing as far as difficulties in daily life. Sadly, even though, as I mentioned, the optimism of the research and progress that's potentially coming soon, there's currently no treatments that actually reverse the symptoms nor the progression of Alzheimer's dementia. But there are commonly the variety of medications that I'll point out here that a primary care provider or a neurologist will, in shared decision with patients, the early symptoms of memory changes or other difficulties. And so you may have been familiar with these through relatives or yourselves, but the Aricept, the generic name donepezil, I won't go into all the details, but these work by moderately or mildly improving the actual brain functioning with the state of disease that it has at a given point in time. It doesn't do anything about the underlying cause of that continued decline. Newer treatments like Leqembi are immune-related therapies that along with other studies and other agents are hoped to one day actually address directly the brain decline, brain degeneration, and improve or reverse symptoms, but that's still a work in progress. So these are used commonly. They're commonly tolerated reasonably well, but can, up to about a fifth of people can have nausea or diarrhea, fatigue, sleeplessness. These actually can improve these symptoms in the first few weeks of treatment. And it can be a different drug that's useful for different people. So trying a different medication, if there are persistent side effects, is reasonable. But this decision obviously is made in conjunction with providers relative to other parts of someone's medical conditions. And families are often the best judge of whether it's been helpful or not. The tests that Dr. Simon mentioned, other tests that measure sort of thinking and cognition, are really not sensitive enough to detect what family may observe actually of what existed prior to the trial and what existed afterward. And then there's a shared decision relative to side effects as to whether it should be continued, especially when disease is more advanced, when the benefits become less so. Next slide. And related to sort of prescribed treatment is certainly the question that others and that you read about in the press and advertising abounds regarding other agents, over-the-counter agents, supplements, vitamins, and other agents that are products sold that are either believed or purported to improve symptoms. And the evidence from the clinical trials on these is mixed. There's best data for B vitamins, as we mentioned here. Certainly, B vitamins are involved directly in neurologic, both maintenance and decline, brain maintenance and decline. So there's been modest benefit for those at the earliest stages with B vitamin supplementation. The rule of thumb for all of these is that never to be taken in excess, to be taken in conjunction with advice from providers. And then there's, we mention others because they're commonly in the lay press about curcumin, Prevagen, and other supplements. There's little evidence that they are of benefit. And as I mentioned here, if you want to try it, you certainly would want to be discussing it with your providers. Again, the judge of their benefit would be in the eyes of family beholders and persons themselves, patients themselves.
Yes, always a lot of questions about supplements and vitamins. Really importantly, some of the over-the-counter medicines can interact with drugs that you're taking, often heart medications. And so it's just really important if you want to start a supplement to reach out to your team before you start it so we can double check and make sure that there's no reason that you shouldn't take it. So this is just a follow-up for our story. So after Mrs. M goes to her appointment, she will make sure to expect a call back from the team to let them know if there's any findings with the blood work or the imaging tests that have been done. They may offer some medications, as we spoke about, to help, especially if it's early on in the disease. They've been shown to be more helpful. They will help connect you to resources. So this is extremely important, not only for the person who's experiencing the memory loss, but for the family. For those of you who have experienced, as somebody who has dementia or similar illness, there can be a lot of things that the person needs help with. And so that can be a significant, that can have a lot of effect on the family or loved ones as well. So you can make sure to get connected to resources for both the patient and family. I do have some resources listed that I'll go over. And you may end up getting a referral to neurology, a brain specialist, especially if the picture is not clear, or if we want to go for some different testing, or if you're interested in enrolling in a clinical trial, we would certainly refer you to neurology. One really important takeaway is that if you have a diagnosis or not, if you notice changes, it's important to report those, because if we follow up regularly and do some of these tests on an ongoing basis, it gives us a better sense of what's changed, and we can work towards a diagnosis. Getting connected with social workers or other care navigators can help refer to needed services. And then we do have some programs here at the health center that specifically focus on older adults that we'll give you an overview about. And the hope is that with this large team of people to help, including the family and the person experiencing these changes, we can promote the better quality of life and improve functional status over time. So here's the list of some community supports. The Alzheimer's Association is truly amazing. They have a very good website. It's offered in English and Spanish. They have many resources that are for caregivers, for patients. They have a 24-hour helpline, which you can call if you're experiencing an issue with behavior or something else that you just want a second advice on. So that hotline is really great. I've also put alzheimers.gov, which has a lot of great resources as well. UCLA Health has these great caregiver training videos that give caregivers techniques on how to help facilitate activities of daily living without as much stress. So I really love these videos, and they're done in English and Spanish. And then the Family Caregiver Alliance also has some great resources, and their website is in many different languages. So I like this one for folks that speak a variety of different languages, and they also have some great training videos. So we're just going to give a quick overview of our 2 geriatric programs here at the Health Center.
So I am the medical director of our senior care options program, CBOR, which is an outstanding nurse practitioner in the care of our patients. So briefly, SCO is a Massachusetts state program for seniors over 65. We just need to live in Massachusetts. Most are what's called dual eligible, having Medicare and Medicaid. Really, the main criteria is you must have standard Mass Health standard. So it's coordinated care. We coordinate healthcare between the healthcare provider, the PCP, behavioral health, and it's just the whole continuum of the team. So at the health center, we're a team both in East Boston at Ten Grove and Maverick, and also we have many patients at South End. So the team here involves myself. There's some leadership. There's 7 outstanding nurse practitioners, and I think we're up to 8 or 9 outstanding nurses and other supports and social workers who work in the field, using kind of ancillary services of everything that we may need to involve long-term services, which may include visiting skilled nursing, home PT, homemaker service, laundry service, food delivery, PCA service, adult foster care. So we coordinate everything in conjunction with PCP. So the folks would continue to get their care at the health center. We do home visits as well. Certainly, enrollment is voluntary and disenrollment is voluntary as well. The satisfaction rates tends to be extremely high. And again, the service area can be anywhere in Massachusetts. You can choose any SCO program that you want. Certainly, we serve the area around South End and East Boston. And again, the additional benefits include a quarterly spending card that can be used on OTC, over the counter, as well as a good proportion of our patients can use it for healthy food and utilities, transportation, both for medical and non-medical reasons, medication delivery, laundry services, ER services that can come to the house, visit vision and hearing services. I'm sure, Celia, that I'm missing a lot, but that's a brief overview of senior care options at the health center.
Thank you. And our other program is called Neighborhood PACE.
The PACE program, which also serves older adults, as does the Senior Care Options Program, is targeted pretty specifically to those who are nursing home eligible. So among the further down a spectrum of need for supports and dependence for services at entry. And our goal, which I'll get into the details of in a minute, is to enhance the enrich quality of life for folks, whatever the circumstance they may be at that point in time, with all-inclusive care that I'll describe in the next slide, this slide that we have right now. We are center-based. We actually have places in Everett, in Revere, in the Maverick Square area of East Boston, and in Winthrop, in which we bring as much as possible and feasible participants to us. We call them our participants, to us from their homes. Many would have no access without the transportation mechanisms that we have internally to provide them access to socialization and medical and supportive services. So that first check mark that they're in PACE centers. It is the entire spectrum along that wheel of supportive services from primary care, nursing, rehabilitative services, recreation, home care nursing. We're a 24 hours, 7 day a week entity that is linked and by call groups and otherwise with circumstances that can happen at any point, 24 hours a day, 7 days a week. And we care for persons along their continuum in moving from the hospital toward short-term nursing facility care or long-term residential care if unfortunately their needs exceed the ability of a plan of care to provide for continued community living. About 5% of our participants, over time require long-term residential care, but all of our efforts are geared toward preserving community living for as long as possible. And then if you go to the next slide. So the eligibility is a little bit expanded in that it's not solely the elderly, that definition being 65 years or older. There's a group of individuals from 55 to 65 years of age who may be on Medicare disability related to illnesses much earlier in their life that are disabling. And so our age is 55 years or older. And the other requirement we have is that we're meant to be in specific cookie cutter areas. There are several PACE programs in Massachusetts. So our area is Chelsea, Revere, East Boston, Everett, Winthrop, Melrose, Stoneham, the North End, Medford, and Malden. I mentioned that there's a heterogeneity of their dependencies, but most have significant functional impairments that are where our services are meant to assist. And about 40% or so roughly have dementia, various stages of cognitive impairment. A person needs to be able to live safely with a plan of care that we provide in the community with our services. And an enrollment team assesses all of those needs prior and then works in conjunction with both the state to meet those eligibility requirements. We're a state and federally funded program, and we're at about 940 members now across those communities that I mentioned.
Thank you. Yeah, so if you get care here at the health center, you can talk to your team about PACE or SCO if you might be interested. And there are other supports in the community as well. We do have an ongoing lecture series that will be going on for the next few weeks to talk more about some different supports, as well as new therapies and treatments in this space. So please come to those if you want to hear more. But in summary, so some age-related changes can be expected, but if you have concerns, you should share them. Reach out to your team and talk about it, because prevention and early detection are really important to maintain independence and function over time. There are some treatments, as we mentioned. There are new and emerging treatments all the time, and hopefully, more to come. There are lots of community supports to help you, and one of those supports is us. So please reach out if you, have concerns. Reach out to your medical team. And I know we're at time, so I don't think we have much time for Q&A, but I did share our contact information. If you have questions, feel free to email. And I don't know if we want to take a minute to take any questions. If there's one or two questions, maybe we can stay on for that. Okay, I guess we answered all the questions. Well, we thank you for joining us today, and we hope you enjoyed the presentation. Thanks.